So laser is a light amplification by stimulated emission of radiation. So how does this laser act? I think all of you know there are certain energies and which these electrons are transferred from the one part to the other, and they act. So certain substances has the property to laze, that is to absorb the energy in one form and to emit a new form of the light. So on pumping, these lasing substances is able to transfer the electrons from the lower orbit to the higher metastable orbit. So this excited atom in turn decay back into their original orbit of lower energy, thus emitting a newer form of protons. This decaying can be spontaneous or induced, and these protons are then passed through a closed system of mirror, which leads to the light amplifications and delivered as a laser. So with this principle, we also use in ophthalmology and especially in glaucoma, the laser therapy. So there are different properties of the laser which you already know: monochromatic, coherent, parallelism, and brightness. So and over this is a trabecular meshwork where the beam of the light is thrown and it acts over here. So I just want to show you the picture. So what are the uses? This is very important questions among the laser chapter for you, and there are number of the uses, but I have selected some of the important which you can remember for your exam. So glaucoma is currently the leading cause of irreversible blindness of the world over, and laser have made the task of treating glaucoma simpler, and these procedures are being used routinely by most ophthalmologists, even at the very basic level. So we even in the OPD basis, in the day-to-day practice, one or two methods of the laser are being used daily, as it is so common and it is so easier treatment modalities of the glaucoma. So most common procedure for the angle closure is the laser PI, that is which we call the laser peripheral iridotomy, and the laser is the neodymium atrium aluminum garnet, which we call the Nd:YAG laser. So this is a very important questions for you. So you can put 5 marks or 5 star for that also. Which laser is used and where you use. So can you give some examples? So it is very, very important for you. And other procedure we currently includes a laser trabeculoplasty, so which we use for the open angle glaucoma, whereas the Nd:YAG laser PI, which we use for the angle closure glaucoma. So gonioplasty, iridoplasty, dyed laser cyclophotocoagulations, and endophotocoagulation. So these are the different methods where you use for the end stage of cyclophotocoagulation just to destroy the ciliary process, where other methods fails. And laser suture lysis, blade remolding. So we will discuss later in the surgery part, so how the blade is formed, and if that failure of the blades occurs, then remolding can be done with the laser. Iridolenticular synecholysis, so when there is synechia which can be broken down with the help of the laser, and Nd:YAG laser hybridotomy. So India and the East Asia population has a high incidence and prevalence of primary angle closure glaucoma, and which also has a greater blinding potential when compared to open angle glaucoma. So though the number or the percentage of the open angle glaucoma is more worldwide, whereas the causing blindness or the morbidity is more with the angle closure glaucoma, and it is very soon. So the most common procedure being the Nd:YAG laser PI, peripheral iridotomy. So this is the beauty of the YAG PI. So you see where we do in the peripheral part of the iris at the upper 11 o'clock or 2 o'clock position, which is suitable. So there are so many criteria for seeing this, and you will just like a slit lamp, there will be a laser machine where we will put a xylocaine, and we will put a pilocarpine, make a patient ready, and just we will make a hole like this. So this is a PI, which is a patent PI, which is done over here in the case of the angle closer glaucoma. So place peripheral iris under the upper eyelid to avoid the ghost image that may arise through the iris hole. And so sometimes the shadow will come. It will be difficult for us also way to put the way to strike for that. And hello ma'am. Ah, la, la, la. So iris scripts represent the thinner iris segment, and such as which penetrates more easily. So we will see the scripts and all to which part it penetrates nicely. So these are, there are every criteria for that also. And superior nasal position, so is the best position. So because it also avoids from the exactly the from the phobia. And other thing is that it will, the upper portion, it is covered by the lid, and so the patient will not have diplopia or other problems at this site. And other for the open angle glaucoma, we use the laser trabeculoplasty, either argon laser trabeculoplasty or selective laser trabeculoplasty, and the different lenses are used over here. Even in case of the PI also, we use the different type of the lenses like Avran lens like this, and over here also the Goldman 3-mirror lens. This is a 3-mirror lens, but there will be 3 mirrors, single mirror, double mirror lens. So argon laser trabeculoplasty, which implies over here, this is for the open angle glaucoma, and which the success rate is very high, that is 75 to 85%, and the average reductions of the IOP is 30% of the IOP is reduced, and which is used in all type of glaucoma, that is open angle glaucoma, normotensive glaucoma, pigmentary glaucoma, pseudoexfoliative glaucoma. So it acts by enhancing the aqueous outflow and lowers the IOP. So this is a method where we put the laser trabeculoplasty, where we do in the pigmented part of the trabecular mesewalk. We try to apply the burns like this, and laser burns are applied like this with the help of the lens. So these are indicated in chronic open angle glaucoma, exfoliation syndrome, pigmentary glaucoma, glaucoma in aphakia, and pseudophakia. So you have completed the lens. So by this time you must know what is aphakia and what is pseudophakia. So aphakia is the absence of the lens, and pseudophakia after doing the cataract surgery where we put the IOL, then that is condition is called the pseudophakia. And cycrophotocoagulation, which reduces the aqueous productions by destructions of ciliary epithelium. So it destroyed at the production site. So there are different techniques of the cycrophotocoagulation, that is which we can through the sclera, transscleral, pupillary area, pupillary, transpupillary, endolaser, and there are different indications for that. That is the failure of the multiple filtering surgery, primary procedures, where if there is severe pain in case of the neovascular glaucoma. So this is almost the end stage of the treatment procedure, painful blind eye, and if surgery is not appropriate. So diode laser, which is frequently done in the almost all the settings of the hospital. So though it is not the easy procedure, it is a very painful procedure. This procedure lowered the IOP by destroying the part of the secretory part of the ciliary epithelium, thus reduces the aqueous secretions. And main thing over here is controls the pain at the end stage of the glaucoma. So where there is a permanent synechia and where other method fails for the treatment portion. And diode laser is also given only after the eye block. We have to apply the eye block over here, and in the case of the diode laser, we cannot apply the laser therapy in almost 360-degree advance. First we will give 90-degree or 180-degree, then only we go for the by seeing the condition. And the other drawback is the eye go into the phthisis at this stage. Now coming to the surgical treatment, which is little bit more important for you for exam point of view than the laser therapy. So surgical treatment, which comprise of the trabeculectomy, which is a surgery which we do when the laser and the anti-glaucoma medication fails. So what are the things we have to consider over here? Surgery is commonly undertaken when the medical therapy fails to arrest the visual field loss. So in spite of, as all of you know, that glaucoma is a chronic and progressive process. So even after the anti-glaucoma medication is there and the patient have got the control of the intraocular pressure, in spite of that, there is a field change or there is some deteriorations when you do the OCT, then you have to go for the surgery. Uncontrolled glaucoma despite the maximum medical therapy and laser therapy. So it says that you start with mono drugs and change the drugs and add the drugs, and in spite of that you give the laser, still the patient, the IOP is high, or if the glaucoma changes are there, so you go for this surgery. In a patient who cannot report for the repeated review, so who cannot come for the follow-up from a far places, failure with the medical therapy and unsuitable for the argon laser trabeculoplasty, either due to the lack of cooperations or inability to visualize the trabeculum. So hazy media hazy is there. And eyes with the advanced disease, that is having the high IOP, advanced copying and advanced field loss, should be treated with the filtering surgery as a primary line of management. So, or if the intraocular pressure is so high that it is unlikely to be controlled by the medication alone. So how you do the trabeculectomy? So when you see, it is a very easy procedure. For the late complications and complications of these trabeculectomies are very difficult to be managed. And first you go like you put like a cataract surgery. So you give a block to the patients and you just make a conjunctival peritomy over here. And making a conjunctival peritomy, which type of the incision you like to do. It is a surgeon choice, which you like to make a triangular flap, or you have to make a square flap, or a rectangular flap. So considering with the Castrovisio caliper, we have an instrument which we measure the size, and the triangular flap we make, rectangular flap we make with a 4 millimeter and 3 millimeter, or even nowadays we do with a very small flap, 2 into 2 millimeter of the triangular flap. So we with the help of the crescent knife, which we make a tunnel. In case of the small incision cataract surgery, we make a partial thickness scleral flap. And after making a partial thickness scleral flap over here, with the help of this pouch, Kelly's pouch, which we make a filtration pathway, just we punch a part of the trabecular meshwork, and we do the peripheral iridotomy at this part, and see the that is aqueous, the flow of the aqueous to the other part of the anterior chamber. We will check, and after that what we do is we put a suture. So if we make a rectangular flap, we have to put a 2 or 3 sutures, and if we make a triangular flap, we can put a 1 suture. So usually I make a triangular flap and make a put a 1 suture. It is very easy, and after putting a suture, you just tie this conjunctival flap very nicely, and at the end of the surgery, so you will see the blade like a shallow part over the upper eyelid, so which is covered by the upper eyelid, and when you will see, it is very comfortable to the patient also. And other part, it is very easy when you do the other part, and you will remove the suture after the 2 weeks part. So trabeculectomy is a surgical procedure that lowers the IOP by creating a fistula which allows the aqueous outflow from the anterior chamber to the subtenon space. And this fistula is protected or guarded by the superficial scleral flap. So the pupil must be myosed. The flap of the conjunctiva antenans capsule is fashioned, and the flap may be lingual or fornix based. So means either it is towards the conjunctival flap when you do the peritomy, either it is towards the limbus or to the conjunctival side. And if scleral tissues is cleared and the outline of the purpose superficial scleral flap is made with the weight filled cautery, and incisions are made along the cautery marks through the 2/3 of the scleral thickness to create a trapdoor laminar scleral flap. So this flap may be rectangular, that is the scleral flap of 3 to 4 millimeter, or a triangular according to our choice. And the superficial scleral flap is distracted forward until the clear cornea is raised, and paracentesis is made in a superior temporal peripheral clear cornea. Anterior chamber is entered through along the entire width of the trapdoor flap, and the block of the deep sclera, that is the 1.5 into 2 millimeter, is excised with a knife and scissor or with the punch. So we have a punch, so the punch, depending upon the punch size, so we do this, we remove this block. And peripheral iridectomy is performed in order to prevent the blockage of the internal opening by the peripheral iris. So this is important. And the superficial scleral flap is sutured at the posterior cornea so that it's tightly apposed to the underlying bed, and alternatively the flap may be sutured tightly with a releasable suture. So some prefer releasable sutures, and to reduce the risk of post-operative scleral flap leakage and shallow anterior chamber. These are the most common post-operative complications. And balanced salt solution is injected into the anterior chamber through the paracentesis. So we use the balanced salt solution as it causes a less cornea haze. And this tests the patency of the fistula and facilitates the detections of any hole or leak in the flap. So conjunctiva tunnels capsule flap with sutures, and irrigations through the paracentesis is repeated to produce a blade, which then check for the leakage, and drop of atropine or tropicamide which we install, and steroid and antibiotics are injected under the inferior conjunctiva. In case of cataract, we inject in the superior conjunctiva. Over here the blade is formed, so we inject in the inferior conjunctiva. So these are the common post-operative complications regarding to the shallow anterior chamber and deep anterior chamber, pupillary block, overfiltration, which is all the malignant glaucoma. So the other part of the non-penetrating type of the filtering surgery is also a deep sclerectomy, or the visco. With the help of the viscoelastic, we do the canalostomy. So, and even we use with the anti-glaucoma, we use the adjunctive antimetabolites, that is the adjunctive antimetabolites inhibits the natural healing response that may causes the more successful in the filtering surgery. So it has got different disadvantages also. So with the cautions, because of the serious natures of the potential complications. So we use this antimetabolites in certain conditions like new vascular glaucoma, previous failed trabeculectomy or artificial filtering, some device which we put, or certain secondary glaucoma or chronic cicatrizing conjunctival inflammation is there. Some dreaded shunt are also put in case after if the filtering surgery doesn't work. So artificial radius shunt are the plastic devices which creates a communications between the anterior chamber and subtenon space. So with the same principle, we use the Molteno implant or the Barbrate implant or the MF implant. So MF ball, which is less, which is more cheaper than the other. So we use this frequently nowadays. So this is a belief after the surgery. So what we have to do is we put the suture like this in case of the trabeculectomy. Also, this is with the valve. So how you put an implant at this site. So more posteriorly you have to go, and which is drained like this way into the this anterior chamber into the subtenon space, and you will put a suture like this. This is with the artificial implant. And but if you do only the trabeculectomy, so just at this site you will make either the triangular flap or a rectangular flap, and depending if it is a triangular flap we will put only one suture. If it is a rectangular, some put two sutures, some put four sutures. So more the suture, it causes more the inflammatory reaction. So one suture is very good, so sometimes two or three suture is also required. So after that you will see like this type of blade over here. This is a blade which occupies almost 2 to 3 quadrant, and it is a vascular area at this side later on. And this at just opposite side or in front of this you will see this PI, peripheral iridectomy. And this is a thing which we do after the surgery. This is a implant which is put, and you will see the implant like this, which is covered with the conjunctiva, and over here it is drained into the anterior chamber. So this is a thing which you do in the case of the this artificial implant. So for the exam point of view, what are the modalities of the treatment of the glaucoma is there the questions. Then you have to write with along with the anti-glaucoma medications, the laser therapy, the surgery, and surgery with the antimetabolites and the artificial drainage shunt. So till there you have to write over. So these are the names. If you remember, you can put it, and sometimes these names can be asked for a practical exam also. So by this we have completed the glaucoma section. So in the next class I will start the retina portion, so you go through it and come, so that you will be able to understand this retina section. It will be easy for you. And later on again, if we get time, we will revise this anti-glaucoma medication. It will be easy for you with a practical point of view, how it will be asked for a exam. So thank you for your patience, and please come a little bit earlier so that you will be able to attend the full class.